Welcome, ladies and gentlemen, to the HCV Model of Care Moving Towards Elimination webinar. Thank you for joining us today. For those of you who have logged in earlier, thank you for waiting patiently. Today, we have lined up a few prominent speakers, and we hope for your interactive participation throughout this session. Without further delay, let me go through the housekeeping messages. Do note that these sessions will be recorded, and if you have questions for the panelists, please feel free to post your inquiry within the Q&A box. You will be muted throughout the session. Should you need any attention, please contact the host through the chat box. We encourage you to view the sessions in full screen mode for better audience experience. So let's start with our first agenda, and let us welcome Jean-Michel for the welcome remarks.
Good afternoon, good morning, wherever you are. So welcome to the first webinar of our Hepatitis C PACT. This is a series of webinars, and I want to give you a little bit of background on the Hepatitis C PACT. So it's an initiative that was launched in July 2021 with some of our partners, which I'd like to thank also for here. So that's Médecins Sans Frontières, TAG, and FINE. And the idea is we feel that low and middle income countries could contribute much more to HCV elimination, and we wanted to create this coalition mostly directed at those countries and encourage them to look at hepatitis C. And in that vein, the series of webinars is looking at experiences from these countries, experiences that maybe we are not used to read about in the medical journals, because they are more, unfortunately, they are not published. So we felt we wanted to create an opportunity, an environment to present some of this experience. And I would like also to thank WHO, the regional office of the Western Pacific region and the Southeast region, who have agreed to partner with the Hepatitis C PACT for this series of webinars. The moderator for this first webinar will be Dr. Riwari, who is a medical officer for the HIV, STI, hepatitis at the World Health Organization, the Southeast Asia Regional Office, and who is providing technical support for 11 countries in that region. Dr. Riwari is a former professor of medicine. He has been involved with the care of HIV-infected persons since the late 1990s, and he led an ART program at the National Aid Control Organization as a national program officer for 14 years, steering it to the world's second largest ART program. He has more than 90 publications and has written a number of books. He has received a number of awards and fellowship of the Royal College of Physicians of Ireland. Before I hand over to Dr. Riwari, I would like also to mention that this webinar will be recorded for the benefit of sharing it later. So just so that everyone knows. Thank you so much. Dr. Riwari, the floor is yours.
Thank you, Jean-Michel and the team for, I must compliment you at the beginning for organizing this series of webinar, taking this initiative along with other partners like MSF, FIND, and at WHO, Southeast Asia Regional Office and Western Pacific. We are pleased to be associated with this capacity building and experience sharing exercise. We know that during the recent World Health Assembly in May 2021, countries around the globe committed to renew the efforts towards 2030 SDG goal of ending HIV, hepatitis, STIs as public health threats. With almost 354 million people with chronic hepatitis and with just around 10% diagnosed and less than 4% on treatment for B and 10% having received DAs, we know that there is a need for innovative mechanism, not only to diagnose those missing million, but also to link them to care. So this calls for high-level advocacy for increasing access to drugs and diagnostics, as well as simplifying the service delivery and community engagement. There are several of good practices identified by WHO which have been published in a document in relation to simplifying the service delivery, And these include simple and standardized algorithms across continuum of care, strategies to strengthen linkage from testing to care, integration and decentralization of hepatitis services with other services, and also very important to increase the community engagement and peer support to promote access and linkages. That includes addressing stigma, discrimination, as well as task sharing, which are crucial to reaching our goals. So today, in this first webinar of the series, we'll be listening to some of the experience from community-led service delivery models from India, Nepal, and a decentralized one-stop model from Malaysia. So to begin with, I would like to introduce our first speaker. Our first speaker is Nalikant Rajkumar, known as Kanta in his community. He is an activist belonging to people who use drugs. For last 18 years, he's based in Manipur, Northeast India, and is now president of Community Network for Empowerment, what is called as CONE. It is a state-level network of 11 community-based organizations with aim to promote and protect health and human rights. Kanta will be speaking on community-led HCV testing model and linking people who inject drugs to HCV treatment. Over to you, Mr. Kanta.
Thank you so much. Respected moderator, Dr. Sariwari, my panel members and dear friend. I'm extremely grateful to the organizer for allowing me to take part in this webinar to present our experience of community-led HCV testing model and linking them to treatment. Next slide, please. So let me just begin my presentation with a brief introductions about our organizations. CONE stands for Community Network for Empowerment, which is a state-level network of community-based organization. It was established in the year 2011. Our organizational philosophy is to promote and protect health and human rights of people who use drugs and allowing them to be treated with dignity and respect, both as human beings and as service consumer. We have 6 key strategic focus area in which advocacy is also one. As a part of the advocacy strategy, we have started working to improve hepatitis C access to testing and treatment in the state since 2014. Next slide, please. So a little bit about the background that where we are working. Manipur is one of the state lies in the Northeast India, bordering to Myanmar. Being a drug user prevalence state, HCV positivity rate is also high as per the studies conducted by CONE. This study shows 43% HCV mono-infection positivity rate and 13% HCV co-infections. Despite of HCV prevalence being so high, the existing national HIV program ignored the critical component for HCV prevention, care, and treatment. Unlike HIV test, hepatitis C test cannot be assessed under the HIV program. Since hepatitis C related component is missing in the HIV program, so awareness and understanding among PACT on hepatitis C is very low. As a result, there is a poor access to hepatitis C prevention, diagnosis, and treatment-related service. There is no government data available or no specific program exists to address hepatitis C in the state. On the other side, from our ground experience, it is learned that the gravity of the hepatitis C among PACT cannot be denied, as many of our friends are dying due to having liver complications. Next slide, please. So, considering the prevailing situation, we have decided to start working on hepatitis C. How and what we have done was we approached Directorate of Health Services, Government of Manipur, pharmaceutical company, and local diagnostic center for collaboration in organizing hepatitis C awareness and screening camp. This is how we begin with the shared responsibility. We identified hotspots where we can emphasize for hepatitis C awareness camp and the hotspot include drug treatment center, opiate substitution therapy centers, prison, and NGO implementing targeted intervention program. We organize awareness camp among people who inject drug and PLHIV community. During the awareness camp, we encourage them for voluntary testing. Whoever tested antibody reactive are motivated for hepatitis C viral load test during the treatment literacy sessions. To make DAA cost affordable, at least to some extent, we started negotiating with pharma company for reduction of medicine cost, bringing down the price from $225 to $55 per bottle. Similarly, we also negotiate with local diagnostic center to provide HCV RNA test at preferential price. We brought down the viral load test cost from $110 to $27. This way, hepatitis treatment using DAA was made realistic for PIVIT community in the state. And for those who cannot afford at all, we pursue pharma company for donation of DAA. At the same time, we also approach individual donors and philanthropic organizations to mobilize funds for hepatitis C treatment. Pre-hepatitis treatment for PLHIV, widow, and PIVIT community become a reality in the state under the project Free from Hepatitis initiated by CON in the year 2016. Next slide, please. And this slide represents the hepatitis C care cascade from the inception of this community-led testing model in the year 2016 till the end of October 2021. Number of people that we have reached out is 9,706. Out of this, 8,414 of them come voluntarily forward for hepatitis C test. 47% was tested antibody reactive, out of which 51% had undergone HCV RNA test. Sorry that I did not convert into percentage on the slide. And 78% were confirmed to have chronic infection through RNA test. And out of that, 55% were put on treatment. Next slide, please. A little bit on the HCV delivery during COVID pandemic that has been taken up by CON. Background of the initiative was due to COVID-19 outbreak, lockdown came into force from 23rd March 2020, and all government and private institutions, including hospitals, were closed except for some emergency cases, and no public transportation was operated. As a result, there was no new enrollment for testing, diagnosis, and treatment of hepatitis C at the model treatment center, as the viral load machine installed at both the model treatment center were exclusively used for COVID-19 tests. This shutdown prompted CON to reactivate HCV services and ensuring that people are accessing testing and treatment services during COVID-19 pandemic. We look for complementing activity and leveraging our workforce to assist and enable the National Viral Hepatitis Control Program function in Manipur effectively even during COVID-19. So between April to December 2020, 28 screening camps at drug treatment center were conducted. The sites were chosen based on sufficient space to maintain COVID-19 guidelines. This targeted decentralized initiative enabled us to screen 908 people, out of which 42%, 378 were found antibody reactive. Of the total reactive, 86% were linked to RNA tests with sample drawn at the drug treatment center itself, avoiding their travel and presence at the government laboratory. 56% of them were found to have chronic hepatitis C infection, and we were able to put 86% of them on treatment under the National Viral Hepatitis Control Program, and 38 of them were achieved SVR 12 week. So the key messages from this initiative was 86% treatment linkages was made possible through community work even during COVID-19 lockdown. Next slide, please. And these are some of the gaps and challenges under the National Viral Hepatitis Control Program. See, for HIV, if anyone wants to go for testing, they can go directly to Integrated Counseling and Testing Center. Whereas for hepatitis C, they have to get the outpatient department ticket first. So while in order to get this ticket, they have to stand in a queue for nearly 2 to 3 hours. After getting the ticket, they will go to the MTC to prescribe for hepatitis C screening test. Then with the OPD ticket, they will come back to another counter to get another ticket. So by the time they reach the blood collection room, it will be already closed. So the working hour of the blood collection room is very limited, and the working hour of the model treatment center is also very limited, as the staff used to arrive at 11 and usually they used to close at 2 o'clock. And another challenge is that I would like to share with you all is the time taken for the HCV viral load test report. It takes from 15 to 30 days to get the report, and this is one of the factors to put away people from treatment. And there is a lack of coordination among the national public health program. Say, for example, like there are a lot of hepatitis C antibody positive patients in ART center. The ART center will not refer them to the MTC for Hep C treatment, nor the hepatitis C people. See, for the initiation of hepatitis C treatment also, they make HIV test mandatory. So if they found HIV positive, they will not take initiative to refer them to ART Center for HIV treatment. So there is a huge gap between the National Public Health Program. And see, in paper, we have 14 treatment center and 2 model treatment center. The 2 model treatment are functioning very well, but the remaining 14 treatment center are not functional due to the lack of medical officer in the state. And the next point that I would like to stress upon is the non-recruitment of peer support staff. This is one of the staff which is supposed to be available at the model treatment center, who is going to take a very important role starting from screening till the patient achieve SBR 12 week. But this particular staff, peer support staff, is yet to be recruited under the national program, due to which community are having difficulty in trying to access the service under the national program. Then under the national program, there is a lack of provision for organizing mass awareness camp. We need to do like how we did in HIV. So due to the lack of awareness among the people, you know, the demand for testing and treatment is still very low. Till now in Manipur, around 1,300 people of them are on treatment. Most of them are referred either by CON or from the OPD, from different departments. Self-direct walk-in patient is still very low. And stigma and discrimination, of course, is another treatment access barrier while collecting blood for baseline investigation and, you know, viral load test, because the staff assume that the one coming from the model treatment center may be from the drug user community, and this became another treatment access barrier. Then baseline investigation. See, we have 2 model treatment center, and the baseline investigation for the initiation of hepatitis C is different. In one model treatment center, they make ultrasonography test mandatory, whereas in the other MTC, the ultrasonography test is not mandatory. That is the reason why people are, you know, approaching to the MTC where ultrasonography are not mandatory. And another issue for baseline investigation is,
Santa, may I request you to please wind up? You have 1 minute more, Santa, please.
Okay. Then next slide, please. So these are some of the lessons learned. Community of this one, PIVOT, can play a vital role in mobilizing people for testing. The more we invest on awareness, the better is in the outcome of people demanding for diagnosis and seeking treatment. And please go to the last slide. That recommendation is more important for us. See, I have 4 recommendations from the community perspective. The first recommendation is why? Because there is no funder who are actually willing to provide support to high risk group or patient group, such as CON or any other, to allow us to do our work. So if we are to achieve the elimination target, there is a need for the community group in the local setting to be supported both technically and with resources. This will also help us to reach out more people. And the second recommendation is, one, the major weakness in the HCV care cascade is people are expected to come and see at the centralized clinic or hospital for screening, diagnosis, and treatment. This has become one of the treatment access barrier. So in order to increase the testing and treatment uptake, there is a need to decentralize these services and take it to smaller towns and cities where primary healthcare centers are located. At least they can start with diagnosis process, and whoever is non-cirrhotic, they can be treated with specialized treatment where specialized treatment are not required. Hepatitis B is a big issue, which is even bigger than hepatitis C, but the progression so far on hepatitis B under the national program is almost negligible. So there is a need for prioritization of mass hepatitis B vaccination among the high-risk population under the national program. And last but not the least, yes, we need to promote hepatitis C self-testing at the community-friendly site if we are to achieve the elimination target by 2030. Thank you so much, Dr. Riwari.
Thank you, Kanta, for a very excellent presentation highlighting the special needs and challenges faced by people who inject drugs and how you have been able to mobilize these people even before the national program started, including awareness, linkage to care. And we can see even during the COVID pandemic, 86% of those the HCV RNA were linked to the program, which is a great achievement of community. We note the challenges that you have brought in, and support to community groups is very essential. And seeing the model by CON, I think this will be a very important thing in future to come in. So with those few remarks, and we'll take up more questions later, I move on to the second speaker. Second speaker is Mr. K.C. Pravachan, who is trained as a social worker. He obtained his master's in gender studies from Tribhuvan University, Nepal. He is also an advisory member of Strategic Technical Advisory Group at CERO. In past 10 years, he has served as a program manager of Sparsha, Nepal, and managed several externally funded projects on HIV and hepatitis C, and had the opportunity of interacting with him on many occasions. So over to you, Pravachan, for your talk on community-based HCV intervention model in Nepal. Thank you.
Thank you, Dr. Riwari. You can hear me, right?
Yes, we can hear you clearly. Please go ahead.
Thank you for the wonderful introduction. Thank you for letting me the opportunity, distinguished member. I'd like to start my presentation.
Yes, we can see it now. Can you make it full screen?
Can you see my slide?
Yes, we can see your slides.
Okay.
Right.
All right.
You can see your first slide, which is showing Sparsha.
I think there is some technical problem or something like that.
Shall we ask the team? Do you need a team to share it?
Yeah, definitely.
So, Mr. Ramanaidu, can you please help?
We will share the slide. Oh, it's working now. Okay.
Yeah. Okay.
So basically, I am presenting about the community-based HCV intervention and model in sports Nepal. So like when talking about sports, it started its journey in 2002 as a support group. And in 2004, like it was officially registered as a community-based organization. And in 2005, like a community-based antiretroviral clinic was initiated through the community. It actually works with people living with HIV in particular and PWID and other key population in general. So in 2012, like it started to run one-stop service model for HIV, hepatitis, and TB, all component as recommended by the technical guide of WHO, UNODC, and UNAIDS. So SPRSA runs a one-stop model, which is basically based on a peer-led outreach model. So we run all set of services from treatment, prevention, care, and support services. So like since most of the community-based model is actually driven by the peer-led intervention. So the community-based HCV model is actually originated from this model only. So basically, we started this community counseling, referral, and treatment center in 2013 because there are lots of myths related to hepatitis C transmission, like testing and treatment. Like hepatitis C is a death sentence. There used to be rumor like people cannot tolerate the side effect of the current HCV medications. Like everyone with hepatitis C is treated with the current HCV medication in the same way. I think slide is not moving. Huh?
So Pravachan, you can tell them to move the slide, so they will move the next slide. You can just say next, like that, okay?
Okay. Next. So basically, we started this hepatitis counseling and referral center with the initiation from SPRSA because there were lots of myths in 2011 and 12, like the hepatitis C is a death sentence. People can tolerate the current side effect of the medications. Everyone will be treated in the same way with the HCV medications. And once you have a Hep C, you cannot get it again. The hepatitis 1 is a worse genotype. Hepatitis C can be sexually transmitted. So this caused fear among the hepatitis C patients. And literally in 2011 and 12, like there was lots of death toll. Next. So there was a high mortality among people living with HIV at that point of time. So people were going to India, Vellore, to access the interferon-based treatment without knowing anything about it. And people were strictly treating themselves by getting the medicine from India, just by doing the antibody test. So there was no treatment available in the country. At that point of time, it was very expensive and there was a market monopoly and people were simply using Google doctors, taking the information from the Google and sharing within the community, and it was creating havoc within the community. Next. So usually in mid 1990, if you look at the literature, the general prevalence, HCV prevalence in general population is 0.6%, and 0.3% of the total adult population inject drugs in Nepal. And at that point of time, the HCV prevalence was 80 to 85% anti-HCV. 130,000 people, individuals are living with HCV in Nepal. And the prevalence of detectable HCV RNA is 42% among PWID. among the total HCV population, only 6% have been treated so far, as per the literature. So due to the lack of knowledge, limited infrastructure and high rate of diagnostic and treatment, it serves as a barrier and people are not able to access the treatment. So basically, next please. So when there were lots of mortality case in 2012, the investment in ART was questionable because people were dying of hepatitis C rather than HIV. So at that point of time, we actually coordinated with treatment access group where we uh, translated the treatment advocacy manual. The sole purpose was to build the capacity of the harm reduction program sites, service provider, to provide a clear information to the people and beneficiary. So in 2004, we came up with since there was no national program for HCV, the export consortium consisting of hepatologists, laboratory experts, people from the community harm reduction program, and HIV prevention program come together and form a group where the HCV prevalence and RL28B study was initiated, which provided enough ground to initiate the short-term interferon HCV-based treatment because it was just the treatment available at that point of time. So it provide the evidence for the country and for us to initiate the community-based HCV treatment model through which people can be treated in a resource low setting. And since while doing this study and providing the interferon-based treatment, we were able to do advocacy to get the approval of the DA, which was recently available in 2015 and 2016 from India. In 2016, Dr. In 2015, Sofosovir and Sofo Lady was approved, and in 2016, Sofo Dakla was approved. Then we revised the protocol, and then the DA-based treatment was provided through the community-based OST site and HCV service site in an integrated model. Next, please. So basically, since in second slide, as I showed you, Sponsor runs a one-stop model, and most of the community-based model run by the Sponsor is actually driven by the community-based peer-driven interventions. So within this community-based model, we have a community lay providers and trained professionals who actually reach client through this model, and they do a pre-screening of the client, provide psychosocial counseling, do a mental health screening, and even a risk assessment of the client, like PHC scale, WHO assessed form, and all. So we also do a coordination and collaboration with the different district partners. Likewise, we also consult with the group of medical expert as well. And the community team was also responsible for providing the logistic management for medicine and dispensing. So basically, since the clinician team will be more focused towards prescribing the medicine, doing all the laboratory tests, all the FibroScan, USG, and preliminary tests, whereas the laboratory, we partnership with the National Center, National Lab, and Center for Molecular Dynamics, where they provide free lab test or the test in a subsidized rate. And during all this process, while providing the treatment, we constantly follow up the clients so that they don't drop out from the treatment program. And while doing all this thing, we also continuously coordinate with a different expert, we analyze the data. We also report it to the different national level, district level, and province level stakeholders. Next, please. So basically, in phase 1, we treated through interferon rifavirin-based treatment, and at that point of time, we just treated 46 people, where the undetectable SVR rate was like 82.6%. Next, please. So model was actually integrated in the existing community model and social opioid substitution therapy sites. So we also treated with DAA. Next, please. We can go to the next. So we also did hepatitis B service antigen and also vaccinated with hepatitis B vaccine to the client, and we provided interferon-free DA-based treatment regardless of HIV disease severity, compensated or decompensated. Next, please. So like through this DA, either it was treated for 12 or 24 weeks. Next. Next, please. So we the treatment outcome was quite interesting. It was 97% in phase 2, and in phase 3 it was 80%. So we quite achieved a very good result. Next. So this community-led engagement led to the partnership with the private agency to provide testing and treatment in a subsidized rate. Likewise, new HIV drug, raltegravir and azotenavir was made accessible under the HIV program to treat co-infected patients. And there was national HCV treatment guideline. We came up with the national HCV guideline and treatment strategic and cost reduction plan. Likewise, we were involved in technical working group and stack. We were able to do a evidence-based advocacy. Next, please. So then the National Center for AIDS and STD Control was also nominated as a focal point, where we are about to provide a treatment to 350 to 400 patients through SOFO and pan-genetic medicine. So we have also come up with the HCV community-based guideline in collaboration with NCAC, and feasibility study of community HCV testing was also done. Next. So basically, the main thing is like the community-based model. Whatever we learned during this process is like, this community-based HCV treatment model can result in an excellent treatment outcome in difficult to treat population like low-income country like Nepal, where despite of client profile, disease severity and HIV status, the case example shows that it has demonstrated that HCV treatment, screening and such services can be provided with a very high treatment response despite the severe 2015 earthquake in Nepal. The service was provided on uninterrupted basis. So even in situation like in COVID or any unforeseen event, the community-based model can be used very efficiently. The model can be replicated in very low threshold, in low cost, in existing harm reduction program or HIV prevention and treatment program. Since the HCV is concentrated in a specific group like PWID and PLHIV, the community-based HCV model can be used as a micro-elimination strategy to complement to the goal of eradicate viral hepatitis by 2030. And the parallel approach of screening and vaccinating the key population for hepatitis B is most effective way of HIV hepatitis prevention and can be built or interlinked in the existing HIV and harm reduction program. So it means like the stitch in time saves 9. Likewise, if we will be able to use the community-based model in this way, like we will be able to utilize the resources in more of for providing a treatment to the targeted community. Thank you very much.
Thank you, Pravachan, for an excellent example of how can community actually lead the national program, basically to bring out the guidelines. I'm aware that the national guidelines and community guidelines came almost parallel and in synchronization with other. It's a good example of micro-elimination because the ART and HCV program are integrated within the same program, and you are able to interact at the OST sites and the ART sites also. But we really know that community in Nepal needs to work more for a full-fledged national program, which is still to come in Nepal, and community has taken a lead and needs to continue that role in Nepal. Thank you very much once again, Pravachan.
Thank you.
So we move on to another example, which is example of we take another example of a simplified and decentralized one-stop HCV care in Malaysia. The speaker is Dr. Muhammad Abul Hassan, who is a consultant physician, gastroenterologist based in Sultan Bahia Hospital, Malaysia. He is currently head of services of internal medicine and Ministry of Health, and he has led this national treatment program for hepatitis throughout the country. Has been involved in research activities, clinical trial, including the STORM-C clinical trial for Sofbuir with Remdesivir along with DNDi, and also Head Start study, three-country study by FIND on Hep C diagnostic. The primary research focus of Dr. Hassan covers gastroenterology and hepatology with particular interest in viral hepatitis, NAFLD, and colorectal cancer. So over to you, Dr. Muhammad Hassan.
Thank you very much, Dr. Riveri, for a very kind introduction. So what I'll do is that I will share the experience from Malaysia, our journey towards eliminations of viral hepatitis C. So next slide, please. Okay, the prevalence of hepatitis C in Malaysia is not that high, but however, we take it hepatitis C as a serious burden to Malaysia because we know the fact that it is curable. So we feel that it's our duty to make sure that every patient of hepatitis C in Malaysia will have the access for the treatment since it is curable. So it's becoming like a human right issues already. The next slide, please. So the following are a few milestones, important milestones in the hepatitis C eliminations in Malaysia. I will start off somewhere in 2016, whereby we, unfortunately or fortunately, I'm not quite sure how I'm going to put it there. Malaysia happened to be in the upper middle income country, so we don't have the privilege of having a generic DAA. So hence we have to do negotiations with the pharma company in order to bring down the price to make it affordable. And we all know that the initial price, the original price of the DAA is exorbitantly high. But we failed to do so, the negotiations, so we have no choice except to opt for what we call this compulsory licensing. What does it mean? Literally bringing the generic medicine to Malaysia to make it affordable. So this is what we have to do. So we have no choice. So we used our government's rights or compulsory license in order to bring in our Sofosbuvir to Malaysia to become an affordable price. Because we all know the fact that in order for us to provide the treatment, the first thing that we need to have is the affordable cost for the price to be accessible to the patients. So this has brought in a major impact in terms of the treatment for the hepatitis C in Malaysia. So by having this compulsory licensing, in 2018 itself, we started to treat our patients with SOF and DEC, Sofosbuvir and Daclatasvir at a very affordable price. And you will not believe it that we managed to bring out the price of SOF and Dacla using this compulsory licensing at the price of $300 US, which is equivalent to about 1,200 Malaysian ringgit. That was in 2018, but the price is even lower now. It's almost like about $100 US. So this is one of the major impact of the compulsory licensing to Malaysia, making the cost of the drugs is accessible and available to all the patients needed. Because this is the key point. And then from 2018 itself, it was quite easy because we have all the patients which already been linked to the hospital. They're all there, the cohort of patient hepatitis C. So we easily finish off treating all of them. And then we start to realize that there are a lot more patients because we all know that the majority of the patients with the hepatitis C, there are all people, majority of them will be people who inject drug. Okay, and then we start to realize that, well, most of them are in the community. So we are saying that they are not coming to the hospital at all. So with that, in 2019, we start what we call this the decentralization process. And one of the major success, the one that we have done, was in collaboration with FIND. We did the Head Start study, and then we have proven beyond doubt that the way to go for the treating hepatitis C, especially among the people who inject drug, is by decentralizations, i.e., bringing the test and treatment or the care for hepatitis C to the community, or bringing indirectly to the patients in the community. So this is the way to go. I mean, and then we have proven that this is the way to go in order to treat our hepatitis C patients everywhere. And in 2020, so we could quickly extend all our hepatitis, all our healthcare facilities, our primary healthcare facilities in the community with the facilities to treat hepatitis C. So the next slide, please. The next slide will show to you the impact of the decentralizations as to the number of patients to treat. The next slide, please. Okay. If you look at, I mean, we managed to obtain compulsory licensing somewhere in 2017, and we started to treat by mid of 2018. And if you can look at from the graph itself, pre-era or the pre-DAA, where we used to treat with the interferons, were barely about 300 patients per year that we managed to treat with hepatitis C. But with the DAA and also with this affordable price, and they are accessible, while the number of patients have been treated has increased tremendously. And in fact, when we first started, we just started with 1,200, but eventually, I think, for example, in 2020, despite of the COVID, we managed to treat about 4,000 patients. So it's a remarkable, and it's incredible to see that all the facilities in our country have started to treat the hepatitis C, including not just healthcare facilities, but we have also extended it to the rehabilitation center as well as the prisons. Well, I must say, I have to admit that the prisons, we are still grappling because there are a lot of issues of treating hepatitis C patients in the prisons. We still have problem because it is not solely under Ministry of Health. This belongs to another ministry, so it's still in negotiations, but the work has started. And then we have screened prisoners among the in the prison itself, and I'm quite optimistic that we will manage to treat as many patients as possible among the prisoners as well. But there are other places, for example, like the i.e. the rehabilitation centers, and also in the community base, is doing very well at the moment. And I know that I think we have to carry on and try to extend our decentralization as many as possible to cover all the patients of hepatitis C in Malaysia. Next slide, please. Yeah, before I move on to this slide, probably just briefly to highlight a few points regarding the COVID impact. Well, Malaysia is also one of the countries which has been impacted by the COVID, and we were hit quite hard as well, like any other countries. But I must say that the fact that hepatitis C, where majority of the cases that we have is a non-cirrhotic, and there's no urgency. So in terms of the initiations of the treatment, I think it's been affected to a certain extent, but there's not major issues because we can always either get the patients to go to another center, another health facilities, or wait until the situation is a bit better. So there's not major issue. In terms of the continuing the medicines, so on and so forth, in COVID, probably I think we managed to maneuver in such a way that it will not be affected so much. the continuations of the medicines. We introduced the postal. We post the medicines to the clients. So this is among examples that we have done in order to cope with the COVID situations. Okay. Another key success in this endeavor will be that how we have to make it simplified. So this is the model or the workflow. I wouldn't say this is an algorithm. It's more of like a workflow that we do to show how it's almost like a one-stop center, but it's not exactly. What is actually the most simplified is that the clients will just stay put at the healthcare facility. The PHC is a primary healthcare facilities. So once they have the screening at the primary healthcare facilities, they will have those who are positive, they will have the confirmations by the viremia, and they will have the evaluations of their status, and then they get the treatment initiations. So everything is done at the healthcare facilities. Wherever that is needed, for example, like the confirmations of the viremia, whereby only the blood will move out to the central lab or to the hospital, whereas the patient will stay put at the healthcare facilities. So this is more of like a one-stop center or community-based as much as we can do in order to simplify the model, not just to the patients, but also to the healthcare provider. And those who are, majority of these patients, the one that we have so far, they all have responded to our treatment, soft and dark pathway. And from our audit, 95%, more than 95% has achieved SVR. And those remaining who have not achieved SVR, we will put them on the second line treatment. The next slide, please. Okay, so it looks quite easy on the presentation, but I must say that we need a lot of effort, we need a lot of coordinations and teamwork in working towards the eliminations of the hepatitis C in Malaysia. The decentralizations will not be a success or will not be a reality unless we manage to get everyone on board. I think this is something which I find it, well, it's a major struggle initially, but I think with the leaderships and also with the commitment from the government, this thing has become a reality. In other words, that we manage to optimize whatever the resources that we have right now. For example, like we have a very good healthcare facility, the primary healthcare facility throughout the country. We optimize the infrastructure. We managed to get the intergovernment multi-stakeholder together. And one important elements which I think which drive us our decentralization process will be our working together with our public health sector as well as our NGOs, locally as well as the international NGOs. And I have to comment, one of the major key driver in our decentralizations will be our FIND, and also the DNDi, who have set like a framework of how the decentralization should be in Malaysia, and we are using that now as our guideline in terms of our decentralization, and we also continuously building up the capacity, the one that we have, and finally also we explore and also we invest a lot also in the research and development, which I will deal with it in the subsequent slide. Next slide, please. Okay, again, I'm actually echoing the same message which I've said earlier. Our journey will not be a success unless we have the collaborations and also coordinations with all the multi-stakeholder, the one that I've shown on the slide here. And again, I would like to express my gratitude to FIND and also the DNDi who have heavily been involved in our journey. Next slide, please. Okay. Having said that, I mean, up to now, Malaysia have treated those patients who are linked to our healthcare facilities, those who have what we call the so-called low-hanging fruits clients. These are the patients who have been linked to us, been registered, coming, or for example, like those who are registered with the methadone clinic. So this is easy because they're all being managed and also they're being treated. But what is the problem that we have right now is to reach out those who are out there beyond this group of people. So these are the people who are so-called the people who inject drugs who are still not under our radar, the sex workers, the MSMs, and the prisoners, of course, the one that I've mentioned earlier. And also, we also have to consider the refugees as well, because Malaysia has a few camps of refugees, and I think we have yet reached out there. Okay, so this is our next obstacle, and this is my next endeavor which I need to reach out this population, so-called the missing millions, who are still out there in the community. For some reason, they're not coming to us, so we have to find ways on how to reach out them. So maybe the next slide, I'm trying to show some of the example that what we can do in order to reach out those still out there in the community which we have not reached out them. Okay, for example, one of the things that we can do is that to do the self-testing. I'm glad that one of the panelists just now, Dr. Kanta, I think, also mentions about the self-testing. So Malaysia is also investing in this. We are doing some project on the self-testing. We have done the usability study and also the feasibility of the self-testing among the MSM as well as the general populations, because we feel that these are the group of people who might not coming to us for some reason, probably because of the stigma and so on and so forth. And also we are embarking on also another study by using the online platform to register for the self-testing. And this is actually, we are sharing together or we are piggy riding on the HIV online register for the self-testing. So we're piggy riding on this HIV platform using the HCV self-testing. And we're also doing some pilot project on the self-test on the one-stop center, whereby everything is done at one center. And I'm thinking seriously about this, whether we should do this thing for the prison. Prisons will be the best setting, whereby we do the one-stop center for the hepatitis C, and we can easily treat all of them, all the patients at the prisons. And the other thing which I would like to share with you will be our DEA, shorten the durations of our DEA project, because we all know that the 12 weeks is pretty long. Perhaps maybe you can shorten it to 8 weeks. Okay, with that, I think I stop here, and I'm happy to discuss or answer any questions for the discussions. Thank you very much.
Thank you, Dr. Hassan. This was a nice learning for us from Malaysia. We are aware about the barriers that have been broken by compulsory licensing in the past, also on the surface of the remdesivir development. But it was really heartening to note that decentralization has been done to 312 PHCs and all hospitals, which is really commendable. And this is one of the recommendations that come from WHO, that decentralization, integration are the key elements to the primary healthcare level if we are able to achieve our goal. We'd like to come back to you to listen more on the community engagement in Malaysia. But as of now, before I take up the questions from the participant, there are some good questions coming in. But I would like to pose one or two questions before that. We heard from Rajkumar Nalikanta what are the challenges basically in community engagement in terms of continuing to deliver this care. So I would like to know more from Pravachan and also from Dr. Hassan to you, what are the major gaps that we need to really fill in, and how can we increase the community engagement, including the community delivery of the HIV, HCV care to patients? So over to Pravachan first and then to Dr. Hassan. Thank you.
Thank you, Dr. Iwari. In past model, when we actually provided treatment for 600 people, like what we experienced was like the community, the people from the community were actually included in all the spheres, from decision making to the program implementation to the planning. And they were also like serving as a service provider, where they provide a conducive environment for people to access the treatment. So I think even like their involvement in a technical working group for like to provide the advice and the recommendation that actually that the community need to provide for the hepatitis C screening and treatment would be very crucial, so that like more people can be access the treatment and they can get the program as per their need and as per the target community nature of the target community.
So there is a definite need from the programs and governments also to support the community engagement, continue the work community has been, and provide the necessary funding and technical support also. So Dr. Hassan, I just wanted to, for the audience benefit, wanted to know more about the community engagement in Malaysia. We have heard more about the program that has been rolled out. So how has been the community been engaged in this endeavor? Thank you.
Yeah, the community engagement is very, very crucial and very, very vital in this work. Maybe I can start off with, because I mentioned just now, I think when we first started the treatment at the hospital level, we have no problem because the patient's already there. The majority of these patients are not people who inject drug or other key populations. We are not dealing with the MSM, we are not dealing with sex workers, we're not dealing with people under custody, so on and so forth. So it's majority, the none of this group who are already in the hospitals. It's easy. And we start to realize that they're not coming to the hospital. So the only way on how to get them is by reaching them. Reaching them is one thing, but another thing is how to bring them to the facilities itself. I think the only way that we can help is that by getting their peer groups or their community engagement, the community group who understand them, who can actually give them some confidence, assurance, and also explain to them about that, and then bring them to the health facilities. So this is, I think, one of the major role of the community-based organizations, that we need to engage them. And true enough, I think when we started the project, for example, like FIND project, we get our NGOs to help us in order to reach out and bring them to the health facilities, because we are still at the point whereby they have to come at least to the healthcare facilities in order to get the test and the treatment. We are not yet going out, but I think we should do that in a while, because there's also another group of patients which are, I would say that there are people under surveillance. These are the people who are under the radar of the police, maybe after they've been released from their prisons or from the rehabilitation center, but they're still under the surveillance. So these are another group of people who are still a lot of them out there in the community. And the only people who can link them to us will be the community-based organizations, people who understand them, who can reach out them. And so this is another area which are another crucial role of the community-based organizations.
Thank you. So we'll take up the questions from the participants. So we have the first question, which is directed towards Kanta. How does the screening yield from the CONE project compare with the established prevalence of HCV among people who inject drugs in India or Manipur specifically? And was there any surprises in the data, particularly when it talked about linkage to the treatment, which was around 55% in the initial part when national program was not there and it was a CONE project? Over to you.
Thank you, Sir Riwari. Yeah, I can see two direct questions to me. One is from Alexandra and one is from Mandy. And the question from Alexandra is about the...
You can take up the first question first.
Oh,
How
first?
does
Okay. This, the one from Mandy.
Yeah.
So was there any surprise in the data? See, when we talk about data in Manipur, there was no hepatitis data available at all. And it was our organization who started, taking up hepatitis C studies first in the state. So, and it was in the year 2014. And I think this question will also, this answer will also serve Alexandra questions. And there were some independent studies available conducted by Indian Council of Medical Research where the prevalence was 98% in Churachandpur district and 92% in Bishnupur district. So the studies was not for the entire state, but for the few district. So that data was not sufficient for us to start advocating government. And this realized us, in order to understand the disease burden of hepatitis C, we conducted studies in 2014. We approached health department and a pharmaceutical company to support us. And in the first study, which was conducted in 2014, the prevalence that we found was 49%. But unfortunately, that studies was conducted without getting any ethical clearance from the Institutional Review Board, due to which we were not able to publish. Then thereafter, we again conducted a new studies, which was in 2018, taking ethical clearance from the Regional Institute of Medical Science, where the positivity rate among the people who inject drug was 43%. And the main purpose of why we conducted the studies was to use as our advocacy tool while, approaching the... and the surprise is we can see the patient, the HCV care cascade, our CONE HCV care cascade clearly show the patient are falling off. We have more number of people tested antibody positive, whereas the number of people that had undergone RNA test is low. Again, when we compare the number of people who have confirmed hepatitis C and who have started treatment, there is a huge difference. So I would just like to request Mandy that what actually he want me to answer from my side. Surprise in the data means while linking to the treatment, see, before the national program started rolling out in India, the person has to spend all the costs both for the medicine and diagnostic out of their pocket expenses. For few individual, the price for the medicine and the price for the, what you call the diagnostic cost that we bring down after having a series of meeting with different pharmaceutical company and different diagnostic lab. Some people can afford, and the majority of the people cannot afford even that, even the cost that we brought down. And for them, we mobilized some fund, and that was how we started, providing hepatitis C treatment in Manipur. So the
we
number
basically
of
meant, Mr. Panta, what we meant basically was surprises was the linkage that you were expecting basically into the treatment. So it was around 55% of the linkage. So that was the point we were trying to emphasize, whether you expected much more linkage or what was the reasons. So since we are short of time, we'll be trying to answer your questions by email also, whatever questions are coming.
Okay.
I propose that we take one question for each of the speakers first, and then if we have time, we can have more questions. So my next question is to Pravachan. Pravachan, can you clarify if HCV RNA testing and the dispensing of DAs happen in the community-based organization, or the clients referred out for these services? And how do we provide basically HCV viral load for the community? Who provides this basically, these drugs and the diagnostics? Over.
Thank you very much, Dr. Rivari, for the question. Actually, the benefit of one-stop shop comes over here. A one-stop model comes over here because for none of the services, like whether it's HCV RNA test or DA dispensing, like it is done within the setting. None of the client have to be referred out for the HCV RNA testing or for dispensing. The lay community provider are being trained. Those people who are working in the harm reduction program are being trained in the program for like medicine dispensing and all, and to do a proper follow-up and monitoring, and providing a baseline and monitoring test and keeping track of that. So in case of HCV RNA, like they just need to come to the community site where their blood will be drawn, and like that will be taken to the lab where the report will be provided to us, and we will disseminate the report. And if there is any confusion regarding it, like we will provide a counseling and whatever expert advice, anything like that will be provided from the same service site. The client don't have to go anywhere. So this helps in like it will help them to keep the appointment, and like the environment will be more secure as well, confidential, and they will be more open up to discuss their issue because we have a team of like we have a multidisciplinary team like hepatologist, even the community worker, those who are actually working for hepatitis. So yeah, but this is how we provide the service. So if the client is co-infected and that need to be start the treatment of hepatitis C and hepatitis C and HIV. So the client can stay in a residential care facility in the organization where the drug interaction can be monitored, and if there is any side effect or something like that, that can be managed by the team of expert from the service side. So
Thank
basically,
you. I think, yeah. Thank you. I think that is a excellent example of actually being in the community, within the community, run by people, and an example of task shifting as well. Of course, I think you will be planning to expand this to other sites across the country, because this might be localized to some sites as of now.
Like even while you're talking about the task shifting, like even the HA are trained in like dispensing the HCV medicine, in the supervision of the expert. So I think like the prescribing will be done by the expert, but the medicine dispensing and the related monitoring can be done by health assistant from the center. Thank you.
Thank you. So our next question is to Dr. Hussain. Dr. Hassan, sorry. Do you have a specific criteria which patient go to second line treatment, or do all treatment failure go to second line treatment? I think the question itself need to be explained what is meant by second line treatment. Over to you, Dr. Hassan.
Okay. I probably did not make it clear during my presentation. What I meant, the first line treatment, the one that we have in Malaysia, is a soft DAC, soft phosphate daclatasway, and it works well. I mean, we have done the audit on that. I think more than 95% achieve SVR.
Okay.
At the same time, we are also looking at the soft ravidasway, because of the trial, the one that we have had earlier, the STORM study, we have shown that soft rabidosway is probably better in terms of the drug interactions, in terms of the co-infection. So the efficacy is about 97%. So that's also another option. We just had our registrations for the rabidosway, so it will be coming out soon. At the same time, we have also, because of our compulsory licensing has expired, so we have also voluntary licensing along the way. So we have soft valve as well available right now. And so what happened now is that for those patients who fail the treatment, i.e. from the first line soft DAC at the moment, so they will be offered the second line of treatment. The second line of treatment, which not many, I think there were very, very few of them, is either we can give them soft valve, or maybe I think we are considering now, once we have our soft rabidosway, also we can also consider soft rabidosway. But also there are probably very, very few patients, very, very selected patients that we may want to consider a very expensive drug, for example, like a soft Volvox or a GP. But this is very rare. I mean, it's a very, very, very selective because they are very, very expensive. And I forgot to mention that in Malaysia, everything is free, i.e. that the testing, the treatment, the laboratory, everything is free. So that's why I think we have the privilege of leveraging these services and to make sure our most important aim is to get this drug accessible to all our patients with hepatitis C. So that's why I think we are doing whatever it takes in order to get the medicines or the treatment to patients who have hepatitis C, because we have all those opportunities and also the privilege of having the drug provided free by the government. Yeah, thank you.
It's good to know that soft DACLA is effective in 95% of the non-cirrhotics in your own experience also. But when we talk of treatment failure, I think I would like to point out that investigation of a failure to achieve SVR with DA therapy should include re-examination of issues of adherence, of potential drug-drug interaction, particularly among co-infected. And we know that currently, if there is a treatment failure, we need to distinguish from reinfection also. And only one pan-genotypic DA regimen, that is soft valproatasavir and voxilapravir, is approved by drug authorities for treatment of person who had a failed treatment. So that was just to add. So before we wrap up this session, I would just like to invite each speaker to say their closing statement. And I would start with Kanta.
Thank you, Doctor. Statement from my end will be, despite of knowing the fact that there is a need for active involvement of community in trying to eliminate hepatitis C, still this is not happening. Rather than we focus on how the community can be involved to achieve the elimination target, we keep on organizing, series of meetings one after another. So it is high time now to turn it into action, how community can be involved, so that we can also contribute toward government effort of eliminating hepatitis C by 2030. Thank you so much.
Pravachan?
Well, from my side, I think the community involvement should not be tokenistic. It should be more realistic, and the community-based intervention is proven to be like one of the most efficient micro-elimination strategy. The proven example is in HIV program, because the prevalence reduction, like everything is being done through a community side. So the government should, promote this community-led intervention, based intervention, whatever it is, to reach more people, and the only way to find the missing millions is the community-based environment, community-based interventions, and their direct involvement in the program. Thank you.
Dr. Hassan, would you like to give some closing statement, take-home message?
Well, we all know that hepatitis C treatment is curative. So I feel that this is the right of every patient of hepatitis C to be treated and to be accessed with the treatment. So if we say that the community involvement is very crucial, so we have to find ways on how that we can work together, especially during this era whereby we have treated certain amount of patients already, but there's still a lot more in the community which are still not covered. So guys, we just have to keep on innovating, finding new ways, keep on engaging our community counterparts, whoever that involved, because I think this is an evolving journey. There's always work ahead that we need to overcome. Yeah,
I think that is a very good comment. Innovations are an important part, particularly the shorter duration DAs, moving to code antigen, also to HCV self-testing. These are some of the things which can really help in accelerating the access to drugs and diagnostics. So I would like to invite now Joe Michel for his comments.
Thank you very much, Dr. Hiwari. I think that was a very interesting session. Again, it's great to have the opportunity to hear these experiences that maybe we don't read enough about, and that is what this webinar series is about. So thank you so much to the speakers for showcasing your great experience in HCV diagnostic and treatment and elimination. So I think on behalf of the partners of the Hepatitis C PACT, Médecins Sans Frontières, PACT, FIND, and DNDi, thank you so much. Thank you to the WHO regional offices for supporting this initiative. And hopefully we'll see you at the next webinar. Thank you so much. I think we are a little bit over time, so thanks a lot and see you at the next webinar.
So before we close this webinar, I would request all the participants to provide their feedback in the feedback link that has been provided. So that would be very useful for us in improving the quality of the webinar. And as to close, basically, we know that success to elimination is basically in engaging all partners, including community. Decentralization to primary healthcare is essential if we really want to reach everyone who needs to be diagnosed and linked to the care. And yes, to begin with, focus on low-hanging fruit like micro-elimination in specific groups, and working on the access to drugs and diagnostic at affordable cost. At CRO, we have just been working on a bottleneck analysis of what are the constraints in access to drugs and diagnostics, and why there is so much of cost difference, and how can we support countries in basically learning from others and support them in actually registration of the drugs at affordable costs. So with these few comments, I would like to once again thanks organizers for organizing this series, particularly starting with a community focused webinar, and also to all the speakers and the whole team organizing, my team at CRO, at DNDi, MSF, and all the partners. Thank you so much.
Thank you.